Very quickly, we're going to talk about the chronic lymphoblastic and myelogenous leukemia. So we have, for chronic lymphoblastic leukemias, we have hairy cell leukemia and the chronic lymphoblastic leukemia by antonomacy. We have, for hairy cell leukemia, the patient presents as middle age or elderly man, and for chronic lymphoblastic leukemia is usually above 60, and for chronic myelogenous leukemia is like to 40 to 70, like the mean could be like 50 or 60. Now, the lymphoblastic leukemia, the CLL is the most indolent of all the ones, present with fatigue, bleeding, infections, but with a mild course. Remember that the infections will be less severe than in those of acute leukemia. And here the pathogenesis is that because there is increase in the proliferation of mature lymphocytes, usually B lymphocytes, there would be production of one monoclonal immunoglobulin if the B cell converts into plasma cell, but there will be no immunoglobulins, so for that the risk of infection. Now, the patient sometimes can produce immunoglobulins against red blood cells or against platelets. This will lead to immune thrombocytopenic purpura, and this to autoimmune hemolytic anemia. So for the autoimmune phenomenon, we give prednisone. The CLL is divided into stage 1, stage 0, 1, 2, 3, and 4. Stage 0 is just leukocytosis. Stage 1 is leukocytosis plus lymphadenopathy. Stage 2, splenomegaly. Stage 4, anemia. And stage 4, thrombocytopenia. The O is low risk, 1 and 2 intermediate risk, and 3 and 4 high risk. The treatment could be reserved for 3 and 4 because 1 and 2, sometimes we don't treat them unless be a lot of symptoms, but certainly in stage 3 and 4 we treat them with rituximab plus fludarabine plus cyclophosphamide. The most important of this one is fludarabine. And even that we have a B lymphocyte expressing CD20, we give rituximab. Now this can be combined also with chlorambucil. Chlorambucil is not as curative as fludarabine, and alemtuzumab. Alemtuzumab is a monoclonal antibody against CD52, and ibrutinib is a monoclonal antibody against the Bruton kinase. So this CLL can present as the indolent course or in the most advanced stages in which we have thrombocytopenia, anemia, and the symptoms. So this would be the treatment. This leukemia is positive for CD5 that is expressed on T lymphocytes usually, but in this case would be expressed for B lymphocytes. It's also positive for CD19, 20, and 23, but negative for CD10 because we're talking about the chronic lymphoblastic leukemia. The best initial test would be the blood smear and the blood cell count, and the most accurate test would be flow cytometry in order to do the evaluation of this and to see which markers, and so we confirm that the patient has CLL. Now, for hairy cell leukemia, and this, remember, on this stage we have lymphadenopathy. This is in contrast to hairy cell leukemia, because in hairy cell leukemia I think it has mainly these characteristic findings. There is proliferation of the B cell with these projections like hairy cells. This would lead to, the proliferation would lead to bone marrow infiltration of just the white blood cells, and because there is also reticulin fibers, there would be bone marrow fibrosis. So we would have a dry tap when we try to take a bone marrow biopsy. So this is one of the characteristic things that we cannot take a bone marrow sample. Second characteristic thing, there is no lymphadenopathy as opposed to CLL. And here is massive splenomegaly because there is extramedular hematopoiesis. So lymphadenopathy here, hepatosplenomegaly here, and the dry tap. Here sometimes we can also have splenomegaly, but this is very, very characteristic of this disease. The other thing is that the cell would be positive for CD25, CD11C, and CD103. So the best initial test would be again blood smear with blood cell count, and the flow cytometry would be the most accurate test, together with the tartrate resistant acidic phosphatase that would be positive in hairy cell leukemia. And the treatment is cladribine, or 2CA. Cladribine is very, very useful for hairy cell leukemia. Sometimes we can also give pentostatin. Now for CMLL, this presents also in indolent course, not as much indolent as in the CLL, but infections, bleeding, etc. Here we have a proliferation of mature myelocytes. This has the most increased risk of converting into a acute leukemia of the proliferative disorders. Remember, this is a proliferative disorder, so we can have increase in red blood cells and platelets. We could also have increase in lactate dehydrogenase or B12 levels. The CMLL is characterized by translocation 922. This is the Philadelphia chromosome. So the best initial test would be the blood smear and the complete blood cell count, but the most accurate test would be the PCR, or FISH, in order to see the translocation. This is the most accurate test. And the treatment would be inhibitors of this mutated protein, or the resultant of this protein, that is a tyrosine kinase. So the treatment would be with imatinib. Imatinib is the first generation inhibitor of this kinase, and if this doesn't work, we give dasatinib or nilotinib, that are the second generation tyrosine kinase inhibitors. Now CLL could be in the chronic phase, in the accelerated phase, or in the blastic crisis. The chronic phase is just like this, indolent course, a little bleeding, infections, etc. The accelerated phase is when there is massive proliferation and there is splenomegaly and thrombocytopenia, decrease in platelets. And the blastic crisis is when CMLL converts to acute lymphoblastic leukemia or acute myeloid leukemia. Two-thirds of the CMLL that converts into acute leukemia would be converted into acute myeloid leukemia, and the remainder 1/3 would be acute lymphoblastic leukemia. So the treatment for this blastic crisis would be treated as acute leukemia, or we can give second generation inhibitors plus rituximab. I'm sorry, rituximab plus the prednisone. Now the CMLL is the only chronic myeloid leukemia, but it's also a proliferative syndrome. So for that, sometimes we can have increase in the platelets and increase in the red blood cells. We can have leukostasis, that is when the white blood cell count is very big, that get locked in the white blood cells in the vasculature, and so the patient presents with bleeding, practice, stroke, myocardial infarction, etc. So for that, we need to do leukoreduction and hydroxyurea. So best initial test for any suspicion of leukemia would be blood smear and complete blood cell count. Usually the most accurate test would be flow cytometry, as in chronic lymphoblastic leukemia and hairy cell leukemia. But in chronic myeloid leukemia, the most accurate test would be to see the translocation on FISH or PCR.